and colleagues. Um, I thank the organizers for giving me the opportunity to present on carcinoma of the hypopharynx. And this is a very special topic for several reasons because the incidence of carcinoma hypopharynx in India compared to Western population is quite high. So if you look at Western population, the incidence amongst all head neck carcinomas is only 3 to 5%. But if you look at the Indian statistics, because of the nutritional and the habits of the patients, we have our incidence at 15 to 20%. So through the presentation, we look at the different sites, their different behaviors, and also the different management outcomes. Harsha, am I audible to everyone?
Yes, sir.
Yeah. So if you look at carcinoma of the hypopharynx, their incidence is about 3 to 5% of all head neck primaries. Now, this is Western data. We don't have Indian data, but Indian data is significantly higher. So we have 15 to 20% of patients with head neck carcinomas who present with hypopharyngeal malignancies. Now, the problem with hypopharyngeal malignancies, unlike the rest of the head and neck, is that they have a higher propensity for nodal metastasis. So, ipsilateral nodal metastasis accounts for about 20 to 25%, and contralateral nodal metastasis accounts for 30 to 40%, which is quite high when you consider their treatment. And about 20% of the patients present with distant metastasis at their presentation. But the more important and more significant factor is that after completion of treatment, a significant proportion of these patients, whether it is piriform sinus or post-cricoid, develop second primaries or distant metastasis. So when you look at the 5-year survival of patients with hypopharyngeal malignancies, irrespective of the treatment and the advances that we have achieved in their treatment, overall from T1 to T4, their survival is less than 40%, and patients who have T4 tumors have survival less than 20%. Now, the reasons for that is because of the submucosal fibrosis or submucosal tumor extension, which is seen as fibrosis in pathology. And also, the submucosal extent is not like oral carcinomas. If you look at an oral carcinoma, the submucosal extent extends for about 1 centimeter in or 0.5 centimeters in all three dimensions, that is length, breadth, and height. But if you look at the hypopharyngeal tumors, there is different submucosal extension for the three dimensions, meaning that when you are attempting a surgical resection of these tumors, we have to take into account the differential um, extension superiorly, inferiorly, and laterally. The other problem with hypopharyngeal carcinomas is their late presentation. Remember that all of us have paired piriform sinuses, and the posterior pharyngeal wall has a lot of leeway. So the presentation for all these patients is quite delayed, and by the time they present to us, they have nodal metastasis or distant metastasis or submucosal spread. Now, in the West, piriform sinus tumors are more common than post-cricoid tumors, But in the Indian subcontinent, post-Krakatoa tumors and piriform sinus have an equal presentation, and that is because a post-Krakatoa carcinoma in the Indian subcontinent is more related to nutritional deficiencies, especially B vitamin deficiencies and Plummer-Vinson syndrome. That is a premalignant syndrome which causes esophageal webs and post-Krakatoa carcinomas. So we have a nutritional component to the hypopharyngeal carcinomas, apart from the predisposition to excessive alcohol consumptions. Now, when we look at the hypopharynx, it is intimately related to the larynx. All of you know that. The epiglottic fold is a marginal zone tumor which can behave either as a laryngeal tumor or a hypopharyngeal tumor. If you have an endolaryngeal tumor, you can have a lot of conservative laryngeal procedures that you can do. But if you have piriform sinus or post-Krakatoa tumors, you are limited to the organ preservation surgeries that you can do. And a lot of our data has been extrapolated from laryngeal preservation surgeries into the hypopharynx. Now, the problem with that is the extrapolation of all the laryngeal organ preservation has ended up with good prognosis for the laryngeal tumors. Unfortunately, the hypopharyngeal tumors have fared worse. So the extrapolation of laryngeal organ preservation to hypopharyngeal organ preservation hasn't resulted in the same outcomes as laryngeal tumors. Now, what are the subsites in the hypopharynx? All of you know it's the piriform sinus, which lies lateral to the trochard and the paraglottic space. The pharyngeal surface of the epiglottic fold, which is the marginal zone tumor that can behave either as a laryngeal tumor or a hypopharyngeal tumor, but in most cases as a hypopharyngeal tumor. We have the post-cricoid, which is behind the cricoid cartilage, and we have the posterior pharyngeal wall. And this is a posterior image of the subsites and the hypopharynx. Forget the false vocal cord. Remember that the piriform sinus is between the lateral wall of the thyroid cartilage and the pharynx. The posterior pharyngeal wall is behind the domain of the oropharynx up to the lower border of the cricoid cartilage. And we have the posterior pharyngeal wall as well. Now, there has been a lot of debate in how you treat a hypopharyngeal carcinoma. Now, before the 90s, there have been a lot of population-based analysis where they looked at the treatment of hypopharyngeal, especially the piriform sinus tumors, surgically. And I will show you the pictures of a surgically treated piriform sinus tumor. And before the 1980s, they found that a surgically treated piriform sinus tumor behaves better than a piriform sinus tumor that has been treated with non-surgical approaches. There's a lot, not a lot, there's one level one evidence and a lot of extrapolation from organ preservation strategies in larynx. But this is a study by Newman where they looked at the SEER database analysis and they found that recent trends more recent trends, not exactly 2010 or 2020, but more recent trends have shown better or a more prediction for radiation and chemoradiation. And they found patients that have been treated with a non-surgical approach for hypopharyngeal tumors, meaning radiation or chemoradiation, did better. Now, this is a very important fact that all of you have to remember. The reason being, this is the only SEER analysis that have shown a benefit for non-surgical treatment of piriform sinus carcinomas. Remember, there is no post-cricoid. In India, we have a significant number of patients with post-cricoid where we have to consider their treatment. Whereas in North America and in Europe, there's a lot of patients with piriform sinus tumors, and this paper by Newman has shown that there has been an increase in treatment with non-surgical outcomes, and the survival outcomes have been benefited by that. So it's 41.3% versus 37.5%. That is the average survival. Now, this is across all stages. I want you to remember this fact till the end of this presentation because T1, T2 hypopharyngeal tumors present and behave differently from T3, T4 hypopharyngeal tumors. And Newman's article also said since 1990 there is a trend towards more radiation than there is surgery. So we are looking at a subset of patients where there is more current treatment modality with a non-surgical outcome. Now, the non-surgical treatment is because the surgery is quite difficult. If you want to preserve the function of the larynx and do a partial pharyngectomy, it is quite difficult to preserve the function of larynx without having the patient to have a single modality treatment. Now, all of you would argue that if you have a T1, T2 tumor of the piriform sinus, can we excise the tumor without burdening the patient with an additional chemoradiation? Now, that has not been found being true, and there's a lot of complications. I will dwell on the topic in the subsequent slides. Now look at the staging of hypopharyngeal carcinomas. It hasn't changed much. We have T1 tumors, which are limited to hypopharynx. I told you that the hypopharynx stages are piriform, post-cricoid, posterior pharyngeal wall, and the marginal zone of the epiglottic fold. T2 is more than 2 centimeters or including one or more subsites of the hypopharynx. T3 is more than 4 centimeters and extension into the esophageal mucosa, and T4 is moderately advanced, and the end stage is quite the same. Now we have three pictures. This is an MRI of a patient who has a posterior pharyngeal carcinoma, and you can see that by an enhancing lesion with central necrosis in the posterior pharyngeal area. So the important thing that we need to look at any imaging, any hypopharyngeal imaging, is to see the local extent because hypopharyngeal malignancies have a propensity for local infiltration. So if it's posterior pharyngeal wall, it's the prevertebral fascia and the vertebrae. If it's a piriform sinus malignancy, it is involvement of the lamina of the thyroid and the paraglottic space in the arytenoid. And if you have a post-cricoid malignancy, that is involving the arytenoid and the subglottic space. So this is a picture of, this is an MRI picture of the posterior pharyngeal wall, and the central hypodensity is because of necrosis. And you can see it's extending from C3 all the way to C6. This is a picture of a malignancy extending from the piriform sinus into the paraglottic space and the true vocal cord. And the third picture is a post-cricoid malignancy with involvement of the post-cricoid space and doubtful extension to the bilateral arytenoid. So these three are important to ascertain the extension of the tumor into the different subsites, and this will make a difference in the management outcomes. So the whole premise of laryngopharyngeal tumors is organ preservation. So the organ preservation started in the Veteran Affairs trial, where they looked at patients with laryngeal carcinomas who had T3 or T4 tumors extending to the base of tongue. And they gave the patients different combinations of chemotherapy with radiation, and they found that patients had a better voice and swallowing outcomes. What are the trials in hypopharyngeal tumors? Now, this might be a bit more for the PGs and the DNB candidates who are doing general assessments and general learning, but evidence-based learning is always important. And I think the following trials will add to your understanding of hypopharyngeal tumors. Now we have 6 or 7 trials. The problem with these trials is that they always combine laryngeal and hypopharyngeal tumors, especially piriform sinus tumors, except for Pradis, where they looked at piriform sinus tumors alone. And all of these trials, if you look at the outcomes, the laryngeal preservation, meaning you preserve a larynx that works without affecting the overall survival, was seen in piriform sinus tumors. So you can give the patient either induction chemotherapy followed by RT or extrapolation from the laryngeal tumors. You can give the patient CCRT with organ preservation. But the essential difference is that the laryngeal tumors, after organ preservation with failure, let's say you treat a T3 laryngeal tumor with concurrent chemoradiation based on evidence, and the patient fails. If you salvage the patient with laryngectomy, their survival is not affected. Unfortunately, if you treat a patient with hypopharyngeal tumors with concurrent chemo radiation or induction chemo with radiation, their survival is not the same with salvage laryngectomy. That is a big difference and unfortunately has not been tested. So your initial laryngeal preservation is the same. Unfortunately, your end overall survival is not the same. So in the current context of evidence-based treatment, I would urge all the ENT and DepNB PGs to see these couple of trials. I'm happy to share the papers of these trials for all of you to understand, but the ultimate salvage is better for laryngeal tumors than hypopharyngeal tumors. Now, the only two studies, I showed you the previous paper where there were 7 studies, but the ultimate two trials which looked at hypopharynx alone, one is the Lefebvre trial and the Bovelian trial. You look at that, and patients who are treated with surgery, remember what I said, surgery followed by post-operative adjuvant treatment did better. Now, this is different from the picture I showed you alone before this, where there were multiple trials where look they had included surgery followed by radiation, and the patients with concomitant radiation or induction followed by CTRT had better laryngeal preservation. Now the problem is in our understanding. Uh, you have to look at either laryngeal preservation or survival. In a larynx carcinoma, laryngeal preservation is more important than survival, or rather, they're quite equivalent. If you treat a laryngeal carcinoma patient without surgery and chemoradiation, and if the patient fails and you do a salvage laryngectomy, these patients have equivalent survival compared to patients who had upfront CTRT. Unfortunately, in patients of hypopharyngeal tumors, where the initial treatment was organ preservation with chemotherapy, and if they fail and you do a total laryngectomy on these patients, they have inferior results. That is because the biology of these tumors is quite difficult. And if you look at the forest plot of the two trials that looked at surgery or radiation, it favors surgery. Now, this is a different topic for us to discuss. We are looking at T1, T2 hypopharyngeal tumors, which are very rare to detect and don't present to us as well. So this forest plot is misleading. So don't look at this. Now, if you have a T1 lesion or a T2 lesion that is amenable to laryngeal preservation. So remember, I will talk to you about what laryngeal preservation is in the next few slides. I told you that the range of survival in a hypopharyngeal carcinoma is quite wide. If you have, I'm not talking about post-cracked carcinomas because they are bad, but if you have a T1, T2 piriform sinus carcinoma that is surgically excisable, they tend to do better than the patients who are treated with non-surgical modalities. And this is the NCCN 2021 guidelines. If you have a T1 or a T2 carcinoma, you have two options which have the same level of evidence. Either you can give definitive RT for the patient, or you can operate the patients where you do a partial laryngopharyngectomy. Now, the problem with operating is because the surgical options of these patients are not practiced worldwide. They are quite difficult. They result in significant morbidity, and these patients will require adjuvant treatment after the surgical resection, and the surgical resection can result in tube dependence. So in my personal experience, a T1, T2 carcinoma of the hypopharynx, especially if it's the piriform sinus, I would recommend radiation therapy for these patients. Now, I told you very clearly the level 1 evidence. I know it's not apt for ENT PGs or DNB PGs, but we are living in the era of evidence-based medicine. And I want you to remember that the only level one evidence that we have, level one evidence is the highest evidence that we have, is from the EORTC 2481 891 trial, where they looked at hyperpharyngeal patients who were stage 2 to stage 4, and they looked at induction chemotherapy followed by RT versus surgery followed by RT. So, if you look at the treatment for patients who have stage 2 or stage 4 tumors, remember this is not T1, T2, N0. T1, T2, N0, you have options of treating, sorry, uh, let me go back up. So T1, T2 is definitive RT or surgery. But if you have T2 to T3 with advanced nodal staging based on the EORTC trial, we give induction chemotherapy followed by RT. This is the only level 1 evidence that we have, or surgery or concurrent chemoradiation. And in our department, we give concurrent chemoradiation based on the trial data that we have extrapolated from larynx. Now, let's say you decided to give the patient induction chemotherapy based on the level 1 evidence that we have for EORTC. And then you look at the response after the induction chemotherapy. If you have complete response, you go for RT. If you have partial response, you go for concurrent chemo RT. And if you can't give the patient concurrent chemo RT, you think of surgery and look at other options. But the surgical options and the RT options, I am very clear here. The surgical options or the RT options, surgical or RT, are only applicable as a choice between T1 to T3 tumors. When you have a T4 tumor, you end up with total laryngopharyngectomy, and then you think of the other options. But induction chemo or concurrent CTRT are not really options when you have a T4 carcinoma that is involving the larynx. Now, doing a total laryngectomy and a partial or a total pharyngectomy is quite simple and straightforward. You make a neck incision and you do a total laryngectomy with mobilization of the pharyngeal mucosa, and then you can either have a patch defect or a circumferential defect. But that is for T4 carcinomas. What about T1 and T2 carcinomas, where historically the evidence has pointed to better survivals with surgery followed by RT? The concurrent chemo RT or RT has shown organ preservation in T2 to T3 tumors but hasn't been studied head to head. Now, if you look at the picture, this is the epiglottis, this is the true vocal cord, and this is the piriform sinus. Now, there are two ways to excise the tumor bearing region in the piriform sinus. Please make a note that the forceps is holding the aryepiglottic fold, and this end of the dotted line involves the aryepiglottic fold. So a partial pharyngectomy for a piriform sinus tumor involves the aryepiglottic fold, involves the false vocal cords here, involves the arytenoid, and part of the interarytenoid mucosa, and this is called a supracricoid hemilaryngopharyngectomy. And this is ideal for patients who have piriform sinus and ipsilateral hemilarynx above the cricoid cartilage, and the ipsilateral hemilarynx is because of the pharyngeal surface of the aryepiglottic fold. So what are the surgical options? The previous slide looked at the surgical options for a pure indolent piriform sinus tumor. So the surgical options are pharyngotomy, a lateral pharyngotomy for a posterior pharyngeal wall tumor or a lateral wall of the PFS. Lateral wall means that you have no involvement of the medial wall of the piriform sinus or the paraglottic space, so it's quite easy to excise the lateral wall, and usually the thyroid lamina is preserved and can act as a reconstructive strut for the piriform sinus. Then you have a partial laryngopharyngectomy, which is useful for piriform sinus tumors and marginal tumors of the aryepiglottic fold. Or you can do a supracricoid hemilaryngopharyngectomy or an extended version of that, or a vertical partial hemilaryngectomy, or the Erkin's technique. Now, the basic principle of a pharyngolaryngectomy surgery is that you resect the piriform, you cut the patient's vocal process and take the vocal cord, and you come across the anterior commissure and take the thyroid cartilage, and this is the picture of the resection. Now, these are the cuts. How do you enter the pharynx? That is by a lateral pharyngotomy at the PFS. Once you detach the mucosal attachments and resect it laterally, this is the epiglottis. This is the tumor in the piriform sinus. You excise all of that with the part of the epiglottis, because a piriform sinus tumor, by virtue of its aryepiglottic extension, can go to the epiglottis, and you resect part of the epiglottis, and this is the defect that you have. There is no arytenoid here. There's intact interarytenoid mucosa. There are two vocal cords. And this is reconstructed by the remnants of the interarytenoid mucosa and the vallecula. And this entire arytenoid is totally blind sacked, and the patient has a functioning vocal cord mobility. So this is PLS, that is partial laryngopharyngectomy surgery. Now, if you don't have vallecula or the epiglottis, we can repair this by the pre-laryngeal muscles, that is the strap muscles. You can do a mucoperichondrial flap or platysma and myocutaneous flaps, free flap reconstruction, or tracheal advancement with buccal mucosal flaps. Now, the previous surgery that I mentioned to you was a patient who had an isolated pharyngeal defect that was not involving the medial wall of the piriform sinus or the apex of the piriform sinus. So, if you have vocal cord fixation, meaning paraglottic extension into the piriform sinus, if you have interarytenoid area involvement, if you have apex of piriform fossa involvement, if you have involvement of the cricoid cartilage or involvement of the thyroid cartilage, you will need a total laryngopharyngectomy. So you see in this picture, that is C, the patient has a tumor in the piriform sinus, and the entire cuff of piriform sinus mucosa has been excised along with the laryngeal musculature and framework. Now, this is after the excision. This is the base of tongue, and this is the cervical esophagus. Now, when you do this, you have to understand there are many ways to resect the piriform sinus mucosa. If you can excise one half of the piriform sinus mucosa, and you have 6 to 8 centimeters of mucosa in the posterior pharyngeal wall and the contralateral piriform sinus mucosa, you can attempt a primary closure. Now, the advantage of primary closure is manifold. You are putting in primary mucosal tissue into the reconstruction. There is no incidence of stricture and a low incidence of pharyngocutaneous fistula. This is quite, the external effect is quite seen in this picture. Piriform sinus tumor on the right side, and you're looking at a picture where there is enough posterior pharyngeal wall mucosa. But sometimes we don't get the 6 to 8 centimeter mucosal remnant of the pharynx. So we have to look at it as a patch defect, meaning we have 3/4 of the pharyngeal mucosa intact, or a circumferential defect where we have no pharyngeal mucosa left. So in a patch defect, we can use the pectoralis major muscle, the DP fasciocutaneous flap, that is the deltopectoral fasciocutaneous flap. We can use the supraclavicular fasciocutaneous flap. These are all pedicle flaps where the patient has post-radiation or chemoradiation salvage. If it's an upfront patient where there are vessels available for anastomosis, I would consider a radial forearm flap or an ALT flap. Now, the Wookiee flap, I suggest all of you to read because it's an historical important flap where they use the cervicophageal skin in stage procedure to reconstruct the pharynx. Now, if you have a circumferential defect, meaning there is no posterior pharyngeal wall or there is no piriform sinus mucosa, we have to think of it as a circumferential defect. We can tube flaps because you need a tube reconstruction between the base of tongue and the esophageal segment, because you'll be resecting from the base of tongue the entire laryngopharyngeal segment. And you'll need a tubed pec major, tubed supraclavicular, and then free flaps are tubed ALT, jejunum, and gastric pull-up. Now, this is the Ong's procedure, and this is a quite common question that is asked in the exam for ENT and ENP candidates. Now you have to remember, if you have a post-cricoid malignancy, that is tumor behind the cricoid cartilage. Now the cricoid cartilage is important for the cricoarytenoid articulation. If the post-cricoid mucosa is involved, it means that there is involvement of the cricoarytenoid joints, meaning there is no meaningful preservation of the cricoarytenoid articulation. And because of the proximity of the post-cricoid mucosa with the esophageal mucosa and a high predisposition for submucosal spread into the esophagus, we are left with no option in a post-cricoid malignancy rather than to resect the larynx as well as the esophagus in our oncological resection. This is a picture where the larynx and all of the musculature with the esophagus and the cut end of the gastroesophageal junction. This is a picture of the total laryngopharyngeal esophagectomy. Now, when you resect a patient with total laryngopharyngeal esophagectomy, you are left with a circumferential defect. This is the total pharyngectomy, remember. This is cut at the base of tongue and at the gastroesophageal junction for the esophagus. So the patient has no conduit at all. We have to find a way where we can re-establish a foot passage between the base of tongue and the lower or the mid uh, um, gastrointestinal continuity. So Ong, this is called the Ong's procedure. Ong found a way where we can mobilize the stomach based on the right gastroepiploic arteries and then mobilize the stomach to the base of tongue, and the base of tongue is anastomosed to the fundus of the stomach after closing the GE junction. This is called the gastric pull-up, right gastroepiploic arteries and sometimes the right gastric arteries through the posterior mediastinum to the base of tongue where there is a hole made on the fundus of the stomach and that is anastomosed. So please remember to read about Ong's procedure, and this is a VFS where the barium travels through the stomach into the stomach. Now, as I told you, there are partial defects and circumferential defects. Partial defects can be closed by a skin patch. Circumferential defects can be closed by a tube skin patch or a visceral replacement. Visceral replacement is a jejunum. And this is from Cesare Piazza's article. The problem of replacing skin with mucosa is that there's a higher incidence of stenosis, but a slightly better voice outcomes compared to visceral flaps like the jejunum. A flap failure is quite high in jejunum, but quite low in PMMC and gastric pull-up. So we have to weigh the differences between speech outcomes and flap morbidity. Now, when you decide to remove a tumor from the hypopharynx, we have to take into consideration the margins of the tumor. These margins are not the same as oral squamous cell carcinomas, they are different. So, Ho looked at the margins that need to be resected for hypopharyngeal tumors. He classified tumors into three types. If you have a smooth rounded contour and there was submucosal extension, that was a type 1 tumor. If there was tongues and islands of tumor infiltration into submucosa without gross examination, they were type 2 tumors, but there were skip metastasis or skip extension of the tumors, they were type 3. And obviously, type 3 were worse than type 1 tumors. So, based on their study, Ho study is a seminal study, and based on Ho's tumors, we have to look at a minimal resection margin of 1.5 centimeters superiorly, 3 centimeters inferiorly, meaning that it will go to the cervical esophagus, and 2 centimeters laterally for patients treated with surgery. Now, the salvage that is after organ preservation, that we treat a lot of patients with concurrent chemoradiation, and we have to do a lot of salvage if the patients fail. which is quite common. The failure can happen 6 to 9 months after the initial treatment. So, what is the problem of salvaging after organ preservation? Now we are comparing the salvage after organ preservation for laryngeal carcinomas. So the problems here are increased morbidity like pharyngocutaneous fistulas won't break down, and unlike laryngeal carcinomas, which have not shown a decrease in overall survival following organ preservation, hypopharyngeal tumors show poorer outcomes of survival in the long term. And if you're reconstructing a hypopharyngeal defect, please use a pectoralis major muscle, myocutaneous or a myogenous flap to uh, you know strengthen the pharyngeal reconstruction that you have done. So, in conclusion, these are aggressive tumors, high propensity for nodal and distant metastasis. The recent SEER analysis have shown a trend towards organ preservation for PFS tumors, but in most post-cricoid tumors, we need a total laryngopharyngectomy and a gastric pull-up. Prognosis is bad because of second primary and distant metastasis, and always focus on pharyngeal reconstruction and functional rehabilitation than anatomical preservation. Thank you for your patient hearing, and I will take questions now.
Thank you, sir. We'll go to the Q&A session. First question by Dr. Divya Samson. Is erosion of arytenoid cartilage in a pyriform sinus malignancy staged as T3 or T4A? Hello? Sir, can you hear me, sir? Hello?
I can't hear you.
Hello?
I can't hear you.
Uh,
I
sir,
can't hear.
can you hear me now, sir?
I can't hear you. I
Hel-
can't hear you.
Hello?
I can't hear you.
Sir, can you see the chat section, sir?
I can't hear you. I can't hear you. I'm sorry, I can't hear you. I can't hear you. I'm sorry, I can't hear you. Am I audible?
Sir, you're audible, sir.
Sorry. I just tried to increase my volume. I
Okay.
couldn't hear you. I'm sorry.
Yeah, so I'll just read out the questions from chat section, sir.
Yeah.
Is erosion of arytenoid cartilage in a piriform sinus malignancy staged as T3 or T4A?
Yeah. So if you have erosion of the arytenoid cartilage, and if you look at the partial laryngopharyngectomy surgeries, we can excise the arytenoid cartilage, preserving the vocal process. But the question is that patients will receive adjuvant chemoradiation or chemo or radiation therapy for these tumors. If you are approaching this patient with a transoral laser surgery, then it is accepted. But if you approach these patients from an open partial laryngopharyngectomy, their outcomes are poor.
So moving on to the next question by Dr. Abhijit Singh.
Yes,
Sir,
please.
difference between laryngeal preservation versus laryngeal conservation?
So laryngeal, they are both the same. All of our laryngeal preservation data is extrapolated from for the hypopharynx, all are extrapolated from the laryngeal preservation data. Now, if you have a T1, T2, T3 piriform sinus tumor, mark my words, piriform sinus tumor. These are amenable for concurrent chemoradiation followed by salvage laryngectomy and partial pharyngectomy with more or less no impairment in their outcomes. But if you're looking at a T3 post-cricoid tumors, these tumors have poor functional outcomes with organ preservation. Even though they haven't been included in any of the organ preservation trials, they are still given concurrent chemoradiation. Now, the problem with post-cricoid tumors is that even if you succeed in treating the local disease, 40 to 50% of them will develop distant metastasis within 1 year, and 30% of them will develop second primaries within 1 year. So there is real no reason to do organ preservation in post-cricoid. Aggressive surgical modality is important to restore alimentation in these patients and to preserve the chemotherapy and the adjuvant treatment for the second primary and the other tumors that they develop. Am I clear?
Yes, sir.
Yeah.
Next question. In T1 piriform fossa cancer, how do you classify patients for surgery?
So T1 depends upon whether the lateral wall is involved or the medial wall is involved. Lateral wall is quite easy because you can do an open procedure, resect the lateral wall, use the strap muscles or a rotation flap or a buccal advancement flap or a free flap to close it. The problem is when the medial wall or the apex of the piriform sinus is involved because the apex is not included in the TNM classification. When they are involved, we have to think of resection of the laryngeal skeleton, where partial resections become a bit more difficult. So, a posterior pharyngeal wall and lateral pharyngeal wall, open surgery is quite okay, or a transoral laser microsurgery is okay. But if it's a medial wall involvement with vocal cord fixity, then we have to think of supracricoid or a partial laryngopharyngectomy where the arytenoid is resected without the trochard, as I showed in the pictures. So T1, T2 lateral pharyngeal, lateral piriform sinus wall with no vocal cord fixity is suitably amenable for laser or open surgery. Is am I correct? Is that understood?
Yeah, it has replied. Thank you, sir. Sir, next question. What are the reasons hypopharyngeal cancers presenting with bilateral metastasis? What are
Yeah,
that?
because of the rich lymphatic submucosal lymphatics. Once a piriform sinus is involved, it decussates to the opposite side, and there is a 20%, 20 to 25% ipsilateral metastasis, which is occult, and 40%, 40% contralateral metastasis. And this is secondary to the embryological lymphatic metastasis from hypopharynx. The piriform sinus and postcricoid have a very rich submucosal lymphatic plexus compared to the oral cavity and the oropharynx. And this is an embryological cause rather than anatomical cause. But this is not a big problem because you can still resect uh, and do a bilateral neck dissection. But the problem is, even before they manifest with lymph node metastasis in the neck, 50% of them have distant metastasis at presentation. That is a big number for which we have not found an answer for cure. Am I clear?
Yes, sir.
Yeah.
Moving on to next question. What are the recommendations for margins of resection in hypopharynx malignancies, sir, by Dr. Soumya?
Soumya, I showed you that picture, no? 1.5 centimeters up front, 2 laterally, and 3 centimeters inferiorly. Now, these are whole studies. Who looked at the submucosal extension and weighted that. But if you really follow Ho's recommendation for 3 centimeters inferiorly, where your tumor ended physically, we'll go to the suprasternal notch. So I would suggest that you take a frozen section, but don't have it at 1 millimeter, because those who had 1 millimeter clear margins had worse prognosis than those who had more than 1 millimeter. So I would rather suggest inferiorly is the most important, because of the submucosal spread into the cervical esophagus. I would ask you to have frozen section control of the inferior margins. But inferior margins have to be at least 3 centimeters to account for the submucosal extension, which is really difficult, because if you get 3, you'll be at the suprasternal notch and you'll be forced to do a gastric pull-up. But if you're higher than that, please get a frozen section and get more than 1 millimeter, because 1 millimeter is a bad cutoff.
Yes. Next question. So, can you please comment on gastric pull-up versus jejunal transfer?
Yeah. So jejunal transfer is accepted if you have the lower stump of the esophagus and the neck. If you have the esophagus cut above the suprasternal notch, the jejunum is feasible. But you have to look at the advantages and disadvantages of a jejunum. The options between jejunum is that you can have a tubed pectoralis major, you can have a tubed supraclavicular flap, or you can have a tubed deltopectoral flap, or if you want to go old school, you can have a Wookie flap. But the jejunum is a visceral flap, there is secretion, there is peristalsis, and because it's mucosal, there's less chance of stricture. So if you have a lower esophageal stump in the neck, visceral flap is the ideal flap. But if you're doing an esophagectomy because of submucosal extension, or because the patient has a second primary in the esophagus, or patient has a Barrett's esophagus in the lower GE junction, then a gastric pull-up is the best option, because you're doing a big conduit, patient won't have dysphagia, you're bringing the stomach into the base of tongue, so the swallowing outcomes are going to be better compared to the jejunum. Am I clear?
Yes, sir. Next question by Dr. Abhijit. What is the extent of lateral neck dissection if laryngeal preservation surgery is planned for early hypopharyngeal malignancies? Also,
It
when do
is.
uh, also when do you include central compartment node dissection?
Abhijit, very, 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 very important question. You do a 2 to 4 neck dissection ipsilaterally or contralaterally, depending on the extent of the primary. The prevertebral lymph node we can't really treat, especially if it's a posterior pharyngeal wall tumor. And then, if the tumor extends to the apex of the piriform sinus, you have to do paratracheal and central compartment neck dissection with isthmectomy. Am I clear?
Yes, sir.
If there's a Delphi node, then a total thyroidectomy is required.
Next question by Dr. Manu Babu. For T2 piriform sinus tumor with ipsilateral level 2 N3B node, will the management be chemoradiation plus or minus MND or upfront surgery, sir?
Who asked this question?
Dr. Manu.
Manu, it's a very, very important question that you asked, and seldom do people ask this question. Now, the management of neck and the management of primary are quite different. The management of the primary can be attributed to chemoradiation or induction chemo followed by chemoradiation. But if you have an advanced nodal disease, you have to see the extent of the nodal disease. N3 can be a node which does not involve the IJV or carotid. It can be a node that involves the SCM. Now, there are two options for this. Either you give the patient concurrent chemoradiation followed by salvage surgery. And this is what a majority of people would do. But in my case, this is what I would do. If I feel there is impending erosion or involvement of the carotid, if I feel there is impending erosion or involvement of the carotid, I would do a radical neck dissection and then send the patient for chemo RT. Do you understand?
Yes, sir. Dr. Manu, you can unmute and
Manu, you can argue. Please tell me, Manu.
yeah, you can, Dr. Manu, please unmute yourself.
Manu, you have the mic to yourself.
Yes, I understood, sir.
Manu? Manu, can you hear me?
Yes, I can hear you.
Think he
I
has a,
hope Manu understood. It's
yes,
about bottleneck. Yes, Manu. I would resect and then give chemo radiation rather than not do chemo radiation.
sir. Moving on to the next question and the last question. Dr. Ashita was asking, can you give reference for your surgical diagrams?
Oh, yes. It's all from Silver's book on head neck surgery. If I will upload it on, I don't know how to upload the entire book. Harsha, can you give me a link where I can upload the entire book? Because I'll upload the topics of larynx and hypopharynx because everything from NTL to supracricoid to supraglottic is there. Very clear diagrams. It's a very, very, very old textbook. I am more than happy to share it with everybody in this group. So Harsha, and it's all scanned, so the volume and the space is quite high. So is there any way I can upload all this?
You can upload it in our Telegram group, sir. I can share the link to all the
But
others.
it is like 20 MB, 30 MB.
Yes, sir. You can.
Or shall I upload it to my OneDrive and share the link to everybody?
Yeah, you can
Is it
put it in
okay?
WhatsApp.
To the members of the group now?
Yes, sir.
Telegram is not good, Satyanaran. Telegram is not good because these are all scanned things. If you can, I will combine it to one textbook and give it to you.
Yes,
If you read it, you can do near total supraglottic, and this is the oldest textbook that I have.
you can put it in one drive, sir. I will share the link to all the
The
interested.
OneDrive, I'll send you the link, then everybody can download. Is that okay?
Yes, sir.
To all the participants, let's ask the participants. I don't know how many of them are there. I
There's
can't
80
log
people.
on. I can't log on to anything because everything is muted. And what is
There's
the
80
problem?
participants, sir.
No, I don't know what the problem is. I can't see anything. Everything is blanked out. No, the I got one message that is we have to download. Download is 80 MB or something. You can download in 10 minutes. But you can do NTL, supraglottic. The larynx and hypopharynx chapters are very good in Biller because the Biller chapter is what is given for the other laryngeal and hyperpharyngeal things in other textbooks. I'm more than happy to share. I have no problems.
Yeah, sir. So yeah, we'll conclude for the day, sir. And on behalf of all my audience,
Anybody wants to see supracricoid, supraglottic, partial pharyngectomy surgeries? Anybody wants to see?
yeah, I think every PG would be interested to see it, sir.
Okay, give me 2 weeks. I'll
Okay,
upload the videos on YouTube and then we can share.
sure, sir.
I'll do supracricoid, supraglottic, and PLP.
Yes, sir. If possible, we'll plan a webinar, sir, so that.
ಇಲ್ಲ webinar വേണ്ട. The video is understandable.
Okay.
Everybody can understand from the video.
Yes. Okay.
Uh, I will. Okay, one. Abhijit Singh, how do you? Sorry, Abhijit, I didn't see your entire question. How do you approach N3B node, sir? Upfront CTRT followed by neck dissection. Okay, so this is a very important question. In my book, I would do an R&D followed by chemo RT. Vijay, is that okay?
Sir, good evening, sir. Sir, if you are doing
Excellent.
upfront R&D followed by
This is
chemo
Abhijit.
RT, sir. Yes, sir.
This is Abhijit. Please tell me. Please tell me. I'm
Sir,
sorry.
yes, sir. In cases you are going to do upfront R&D followed by chemo RT, sir.
Yeah.
I mean, how sure you are that the patient is not going to come with, if not loco-regional, maybe distant mets in coming future?
You can't change that. Distant mets is not in our hands. The only factor that prevents distant metastasis is chemotherapy, either induction or concurrent. Concurrent is 6.5%, induction is 4.5%. We can't change that. But what it helps us is that it doesn't interfere with the carotid involvement and the prevertebral involvement. So you're going to do a R&D and then give the patient chemo RT. That is better than doing a chemo RT and then doing a salvage neck dissection. You understood?
Yes, sir.
So I would do a chemo RT followed by concurrent CRT, then doing a salvage neck. Because a salvage neck will never give you R0 resection.
And when will you plan for an induction chemo, sir? I mean, outside a trial setting.
No, currently in head neck there is no indication for induction chemo. I'm sorry.
Okay, sir. Thank you so much. Thank you.
I'm really sorry. There is no role for induction. What is my YouTube channel? Learn Head Neck Surgery. You can see whatever you want there. It's called Learn Head Neck Surgery. You can find 30 or 35 videos of resection followed by reconstruction. All flaps. Whatever flaps you have imagined in your life, I have a video for those flaps. Harsha, can I ask you a favor?
Yes, sir.
Can we have case discussion?
Yes, sir. We can do, sir.
No, the questions that have been asked now, Abhijit asked a very pertinent question. When will you manage an N3B node surgically? This is a one topic class by itself. If you have an N3B node, whether you'll do surgery, Abhijit was a brilliant question. Thank you for putting that question up, Abhijit. So, this is my request to you. Whenever you have time, can we have 10 case capsules where we're looking at all borderline cases? Can be oral cavity, can be nasopharynx failure, can be oropharynx failure, can be laryngopharynx primary, laryngopharynx advanced, nodal failure, nodal advanced. It can be things like that. Abhijit, are you? I mean, Abhijit is the guy who bought this up. Abhijit, what are you doing Where are you? A very important question that you raised today. I'm impressed.
I'm final year MCS trainee head neck surgery at AIMS Hospital.
That is why. Good man. Very good. I understood that.
Thank
Good,
you, sir.
good, good, good. Can you come up with some more relevant questions? This was a very relevant question, but Harsha will be very happy because Harsha is senior. He can collate these questions and make it a case discussion. I'm happy to do these case discussions with pros and cons of everything. Harsha, can we have a discussion on
Yeah,
troublesome cases or borderline cases in head neck with the people like Abhijit and everybody giving their input?
sure, sir. Sure, sir. Yeah, we'll have a discussion on a phone call, sir, after the class.
No problem. No problem at all. I'm happy to do it. Abhijit
Yes.
was a very good, a very smart question. I would take it from him.
Yeah. So, sir, can we conclude for the day, sir? We have
Anytime. Unless anybody has any other question, I'm happy to conclude.
so there are no more questions from the chat section, sir.
Yeah.
On behalf of our PGs and our team, very thank you, sir, for sparing your time.
Oh, no problem. More people know, more people is better. We are looking at a national thing for making our society better. And I have to thank you, Arsha, because you've been more pushing. People who lose interest and people who lose. I think all of the members who attended this meeting have to thank Harsha before they even think of thanking me because they both have been very persistent in getting this done and all this. And I'm very happy to participate. And my interest in teaching, you all know. So anybody who fights with me, I'll be very happy to fight and argue evidence and for exam and whatever. I have a lot of fights with Abhijit, but I'll fight with him next time.
Yes.
I will curse him and ruin him with fights, but we'll do it next time. Yeah. Thank you, everybody. Thank you. God bless all of you. Amma's grace with all of you. Abhijit, thank you very much, Abhijit. God bless you.